This is my opportunity here. I'm actually going to geek out for the next 45-ish minutes. This is kind of sort of my pathway of what I love and going from there. Um, when I talk, when I teach EMTs, paramedics, if you've gone into my classes, begin the class, I always say you have to understand anatomy, you have to understand physiology. If you understand those two things, truly understand it, you can do whatever you want to take care of the patients. All right. If you don't understand the pathophysiology, if you don't understand anatomy, the process through all that stuff, you're not going to do what's best for the patient. And we will go through some of this. Again, just as a refresher, reminder for the anatomy side of it, and then from there, the aspect of the physiology. And we'll talk the pathophys for CHF and STEMIs, again, pulling everything together. At the end of this, just by review of our notes and charts and all that stuff, just for education purposes, listen to heart sounds. And Dietrich's going to send out the link that has a whole bunch of sounds, not just heart, but lungs and all that stuff. And the good thing about that, it's a free website. So to go. All right. Yeah. And this is, my plan is to bring the lawyer from Grady up at some point in time, put somebody into the hot seat, and then just go through a deposition, okay? Documentations, charting, and all that stuff. This is what really does save you your butt sometimes from that perspective. All right. Anatomy, cardiovascular. All right. Just as kind of sort of the heart made up of the three different layers. The epi, okay, the outside layer, the myo. What does myo mean? Middle, or actually, myo means muscle. Okay, so that's the musculature layers, the myocardium. So that is in the middle, and then the endo or the endocardium is the inner layer. The heart does not get food, oxygen, nutrients as blood passes through it. It has to get its blood and all that stuff through the coronary arteries and through the diffusion process. All right, so as blood traverses through the heart, nothing really does anything from there. Cardiac muscle, it's special. Okay, it's unique. It has a whole bunch of different properties that we'll talk about in the future. But the aspect of the intercalated discs, everything fits together. You have the tropomyosin and the troponin. Those are the pieces that help bind the actin and the myosin filaments together. Calcium binds to the troponin and the tropomyosin, and that's what causes the contraction process. All right, so those are the basic deep down pieces of cardiac muscles and all that stuff. All right, getting to the cellular level. Pulsation contracts all the time. We'll go from there. All right. How many heart valves do we have? 4, correct? Okay. So as we go blood, the blood comes from the brain or the head and from the feet, okay? And then also you have blood coming from the heart. So how does it come from the head and the feet? What does it travel from? The vena cava is good, okay? And then from the heart, it actually dumps back into the coronary sinuses, and all that dumps into the right atrium. Okay, so all the blood goes to the right atrium, goes from the right atrium through what valve? Tricuspid valve into the right ventricle. Then it goes from the right ventricle to the pulmonary, through the pulmonary valve, the pulmonic semilunar valve. Okay, to the lungs, comes back. Okay, so it comes through the pulmonary artery, oxygenated or deoxygenated? Deoxygenated. Okay, comes back from the lungs via the. Okay, how many pulmonary veins do we have? 4, correct? Okay, oxygenated or deoxygenated? Oxygenated into the left atrium, goes through the mitral valve into the, and then up through the aortic semilunar valve into the aorta. Okay. So when you're looking at the differences between, again, just as a reminder, the mitral valve and the tricuspid valve, okay, they're different from the semilunar valves. The semilunar valves have little leaflets, looks like a Mercedes-Benz sign, the majority, okay, unless it's a a bad one. Okay, you can have a bicuspid valve versus a tri. So they're usually all tricuspid for the semilunar valves. Okay, they have little grooves, and when they close back down, they lock together. They open up because of pressure. When the ventricles squeeze, it builds up the pressure and it opens the valves. Okay, that's how the semilunars work. The tricuspids and the bicuspids, okay, they have muscles. They have little papillary muscles with what's called the chordae tendineae, which is the thing that actually attaches to the leaflets. And when they contract down, they pull the valves open. What's the problem with muscles? What do muscles do over time? They wear out. So what happens to the valves? They leak, okay? And that's where we get murmurs, specifically the mitral valve when we talk later, okay? The mitral valve is the one that leaks all the time, and it will push back, and you get your regurg and all that stuff, which we'll hear. Right. So again, your tricuspid valve, the pulmonic semilunar valve, your mitral or bicuspid, and then the aortic semilunar valve. Majority of blood, 85% is in circulation. Of that, the majority of that is in the what's called the capacitance vessels. We have conductance vessels and capacitance vessels. Conducting does what? Takes blood from the heart to the organs, and then the capacitance is where they just sit, capacity-wise. So your arteries, arterioles, those are conducting vessels. We can change some physiology into that, but it's really the capacitance vessels, the veins, the venules, and all that stuff. You can open those up a lot, which means that's where they hold blood. Just like boxing up, putting it into storage. Pulmonary circulation, 10%, and then there's 5% of blood inside the heart chambers and all that stuff. Okay. Again, just the flow, right, as a reiteration. Blood comes again from the inferior and superior vena cava, and then also the coronary sinus, this little spot right here in the center atrium, goes through the tricuspid. You can see the little papillary muscles with the chordae tendineae on it. Okay, so there's 3 on the tri. The tricuspid usually, from the aspect that we have a problem, is because of IV drug use.
So the chordae tendineae hold them open, and when they relax, they're closed, and when they contract, they
so the muscles, the papillary muscles will contract, and then it pulls on the chordae tendineae, which then pulls on the leaflets. Okay, so you can have the leaflet for the tricuspids and bicuspids. You get a problem with the leaflet itself, you get a problem with the chordae tendineae, or you get a problem with the papillary muscles. Unlike the semilunar valves, it's just the valves themselves. And usually they become stenotic, hard for the semilunar valves. That's why older patients with aortic stenosis, they need a new valve. IV drug use, again, this is the first place that coming from the body comes back to the tricuspid valve. That's why you get the vegetation from IV drug users and all that stuff. From there, that's the main valve. Arteries. You have the pulmonary trunk, and then you have the aorta. Are 2 major processes. The blood to the heart. Okay, how does it come about? Where does it go? Where does it get the heart get its blood from? Where does the heart get its blood supply from?
It gets it from it's the first takeoff, the aorta.
First takeoffs. Okay. So where are the first takeoffs from the aorta? Okay. So right behind the aortic semilunar valve, there's something. It's the sinuses of Valsalva. Little holes there. That's where the coronaries, and we'll get this into a second. That's where the coronary arteries sit. So when those valves open up, what do? They actually will. They close off, they cover the coronaries. Okay? So if I increase my heart rate to 180, what are those valves doing? They're staying open all the time, which means what?
heart's not getting oxygen.
Not getting any blood supply, not perfusing, not getting oxygen. So what does the heart do? It pumps harder because it's not getting oxygen. It gets pissed off. Right. So the coronary circulation, again, the sinuses of Valsalva. The first takeoff, you have right for the aortic root. From there, right where the seminal valves, they open up. So if you keep open all the time, you can't get blood back in because it's during diastole when the ventricles relax, the pressure in the aorta pushes those valves close, blood flows back into the coronaries. If we have a heart rate of a 180, 200, the valves stay open a long time, which means that we don't have a lot of filling, which in turn means that we're not getting oxygen to the heart. Key things. That's why we have to slow things down. Left coronary artery, okay? Predominantly the left ventricle, the septum from that standpoint, and then some of the right ventricle, the right coronary artery, okay? It does the right side of the heart, and then the conduction system. What part of the conducting system does the right coronary do? What sits in the right atrium on the conducting system? SA node. Okay, so that's why when you kill the coronary, if you thrombus that, or if you dissect the aorta, it'll dissect back through and split the right coronary. That's why how you knock out the SA node. Bad juju. Okay. So the coronaries again coming off. Okay. The left coronary comes over, splits, becomes the circumflex, which goes around, okay, to the left side, and then the left anterior descending. What does the left anterior descending blood supply give us, or what does it supply? The left ventricle and the septum. And what lives inside the septum? What important structure lives inside the septum? Purkinje fibers at the bottom, but getting up there before that is the AV node, the bundle, and then the bundle branches. Correct. Okay. So the electrical system lives inside the septum. So that's why if you knock off the LAD, okay, that's the widowmaker. Okay, that's why they die, because you knock off all the electrical supply. They go into your VFib, VTAG, and peace out. Go from there. The flip side, the back of the heart. Okay, again, the left coronary. The right coronary can dive around a little bit. It may not supply to the posterior, or the left circumflex comes around and it forms the posterior descending, and that gives us our back side of the heart blood supply. So when you do a posterior, your 789 EKG, that's what you're looking at. You're looking at the posterior descending coronary artery. Major vessels for the major veins, 4 pulmonary veins, oxygenated, deoxygenated. Oxygenated, okay? Inferior vena cava, superior vena cava, and then the coronary sinus. Coronary sinus, all does is everything comes back together. Okay, all the coronary veins come into the coronary sinus and then dumps into the right atrium. Systole, okay, that's the pumping phase. Diastole is the relaxation phase. Okay. The majority, let's start off at ventricular diastole. That's going to be our starting spot. During ventricular diastole, what valves open up? Yep, the tricuspids and the bicuspids, they open up, they get pulled down, and then you have passive fluid filling. 90% of the blood that goes into the ventricles is by passive means. It just goes straight through the atriums into the ventricles. Okay. From there, we start the contraction process. So once we start, the atrium start contracting down, that gives us that last 10%. So the atrial systole, they constrict, they push the rest of the blood from the atrium into the ventricles. From there, you have the pressure is the same. The tricuspids and the bicuspids, they close back because of pressure gradient. Then the ventricles start squeezing, They open up your 7 lunar valves, and the blood gets pushed out. And then once diastole, the ventricular diastole, the 7 lunar valves close. What fills up? The ventricles start filling back up again, but what else is being filled at that time? Coronary arteries. Okay? So blood flows backwards into the coronary arteries, and it circulates the blood from there. So anatomy, good with that?
So the heart's not getting its blood until rest days.
Correct.
So it's getting last blood instead of first blood. Even though it branches off first, it's still getting last blood.
Yes, but it's actually the most oxygenated, the richest, because it's coming straight from the lung back into the ventricle, and it's diving straight back into the coronaries. So it actually has the most richest oxygenation. Less pressure from that standpoint.
Gotcha.
All right. Electrical system. What is automaticity? Okay. So automaticity, yep, it does automatically. Any cardiac cell has the ability to fire. Okay. So if it's in the atrium and it's not from the SA node, it fires. What do we call that? AFib. Okay. Or wandering atrial pacemaker, MAT, or the multifocal atrial tachycardia. You can get those. So those are the 3 processes. If it's in the ventricles and they're firing by themselves somewhere else, what do we call that? PVCs, and you get a whole bunch of PVCs together, we call it VTAC. Okay. And if you have no synchrony at all, we call it VFib. Okay. And then the terminal flutter can get it and all that stuff too. Okay. And then, of course, that all leads to the terminal rhythm of asystole. Conduction. SA node, where's the SA node live? Right atrium. AV node lives in the septum, right at the atrial and ventricle junction. Okay. And then the bundled hiss and all that stuff going down. SA node fires. Okay. That's where we see the P wave. That's what the P wave purpose of that. Okay. We'll talk about electrical impulses on the next slide. How do we generate from there? So we have the P wave firing, and then we have the PR interval. What's the purpose of the PR interval?
Ventricle filling.
Ventricle filling is part of it, correct. But what else is the other purpose of the PR interval?
Well, it's the period of time that it can fire back on.
Correct. Okay.
The AV junction is holding that before it fires out the electrical impulse.
Correct. Okay. But why? What do we need to do? Where does the SA node live? The SA node lives in the right atrium. So what do we need to do? Where do we need to get the electricity to? To the left atrium. So how do we do that? It goes down through the Bachmann's bundle, so that's the intraatrial pathway, allows the electricity to go from the SA node across. That's the PR interval. That's when that the electricity is contracting across, and all the atrium is squeezing down, giving that last 10% of our cardiac output. And then the ventricles squeeze and fire with that QRS complex, and then ultimately the T wave for relaxation. So SA node to the AV node pauses, lets everything, that's the gatekeeper, stop, electricity get across, and then it allows the pathway to come down to the bundle, and then your left anterior posterior fasciculars to the Purkinjes, and then contracting from the bottom up. Geeking out, okay? This is where I'm going to real geek here. All right. So action potential, how does this work? How do we get the electricity to fire? The membranes of the cells, or the cardiac cells, they sit at a minus 70 milliamps. Okay? That's just where that's the resting state. They're a negative charge. Sodium's on the outside, and then from there, potassium, chloride, all that stuff is sitting on the inside and then just waiting. Sodium The sodium channels open up. Sodium starts rushing into the cell, and it drives the membrane to a positive charge. Usually gets to 0, positive 10, somewhere in there. You can have the lecture. Yeah. Peter has access, and he's going to send the lecture out to everybody. So it goes from from a negative to a positive. So it gets to 0. Once it gets to 0, then from there the body says, hey, we're good, and it starts dumping out potassium, okay? Pushes potassium out of the cell along with chloride to help balance things. So that's the phase 1. So in phase 2, calcium's like going, hey, I want to be part of the party. All right? So the calcium gates open up, and they start coming into the cell. And what does calcium do for us? What does calcium bind to? That binds to the troponin and the tropomyosin. And what do? They cause the contraction. They get inside the sarcoplasmic reticulum and all that stuff, and they bind to the actin myosin, and they cause the cell to squeeze down. In phase 3, the system's like going, hey, we're all good. Okay. It stops the calcium channels they actually close the gate, so calcium can't get in and out anymore. And then it starts, passes on the outside, and then it gets into phase 4, and it resets everything, right? How does the body reset the sodium and the potassium? What does it do?
Release calcium.
Okay, it'll pump calcium out, but what does it do with the sodium potassium? We have a sodium potassium pump, okay? The sodium potassium pump, okay? 2 sodiums for 3 potassiums, pumps everything through that. Remember at the high school biology? Okay? What does it use as the way of getting the sodium potassium to work? What? It's there, yeah. What's the energy source for our pumps inside the body? Mitochondria, which produces what? ATP. So adenosine triphosphate. Okay. So it uses ATP made through the mitochondria, through the Krebs cycle and the electron transport chain. And that's how it produces this process. Right? What's the old drug that can actually kill the sodium potassium pumps that slows or can do the arrhythmias or stops the arrhythmias? Starts with a D. Not diltiazem, that's a calcium channel. Your Van Gogh drank it, his tea, saw yellow halos. Digoxin. Okay, so yeah, so not D, not dilaudid, no.
That does ultimately stop it, but anyway.
So digoxin is the one that actually does the sodium potassium. That's how we terminate arrhythmias because it kills the sodium potassium pumps. So in phase 1 is sodium channel blockade. What do we carry to do sodium problems? We carry lidocaine. Okay. What do the patients snort sometimes that does this? Cocaine. Okay. So that standpoint. So there's inside phase 2. All right. This is where your diltiazem and verapamil and all that stuff come into play. So that's the calcium channels opening and closing in phase 2 is where that interacts with. Phase 3 is going to be your class 3, the amiodarone that we carry. Amio is sodium, it has potassium, it has betas, it has everything. Just for education purposes. And then our class 2 is the beta blockers into phase 4. So, speaking of betas, okay. So we talked about physiology, so we talked about anatomy. We talked about the electrical conduction system. Okay, the whole process with that, threw on some ions, electrons, and all that stuff from there. Okay, so how do we get the chemical? So we have the electrical control. Now it's more of a hormonal control, and that's what the adrenergics. If you're driving down the road, okay, in your car, someone runs out in front of you, a deer runs out in front of you, or someone starts shooting at you. What happens? What? Yep. So the sympathetic startup, okay? Fight or flight response, okay? What's the hormones that we use for that? Epi and norepi. Okay. So correct. And then we'll also, dopamine's in there a little bit, but we're going to leave dopamine off for now. Okay. So our alphas and our betas. Alpha 1, beta 1 constrict. Alpha 2, beta 2 dilate. So the location, we have alphas and betas all over. Alpha 1s, beta 1s, alpha 2s, beta 2s all over. But it's where the predominance of the location is what their effect is on. What have we been taught? Where do the beta 1s kind of sort of live? Now, in the heart, where do the beta 2s live? In the lungs, the alpha 1s, where do they live? In the extremity vessels, okay? Because when we give Levophed, what does that do? What does Levophed work on? Constricts the vessels, and it does what? When it constricts the vessels, where does the blood go back to? Gets it back into the central circle. So that's where the alpha 1s. And the alpha 2s are actually in the brain. All right, so catapress, clonidine that we give, it's essentially mediated, so it's inside the brain. It has some other places too. So our alphas, all right. Alpha 1, blood vessels, the walls, that's the majority of those. In the peripheral. Mydriasis, well, that's actually dilating the pupil, okay, so that sounds counterintuitive, but it's actually causing the muscles to constrict. When the muscles constrict, that causes the pupil to get open, right? And we want, in a fight or flight response, we want the pupil to be open because, see more, your peripheral vision opens up from that standpoint, so you can get more light in. Urinary retention, and of course, ejaculation. Go from there. The alpha 2s are on the presynaptic neurons inside the brain from that perspective. The betas. You actually have 3 different types of betas. There's more than that, but the major 3, beta 1, beta 2s, beta 3s. Someone asked yesterday, what does the G's mean? It's a G protein. So this is the secondary message process. I can talk about that for hours on end. When you get cyclic AMP and G protein process pathway, but we won't go there. So the beta 1s, heart, kidneys. Okay, kidneys are stupid organs. They are stupid. They don't know anything. Okay, but they do, from the aspect of regulation-wise, they can affect how we do things. They release renin. Renin produces what? Or what does renin do? Right. What? Angiotensin, good. So angiotensin is converted to angiotensin 2. All right. Angiotensin 2 does what? Angiotensin 2 causes blood constriction. So it actually circulates back onto your alpha 2s. Your alpha 1s. It causes blood constriction, blood vessel constriction, and then it also, the angiotensin 2s goes back and it causes the release of aldosterone. Aldosterone is it's like prednisone. It's a steroid. All right. So aldosterone is a steroid that tells the kidney to hold salt. Okay. When we hold salt, specifically sodium, wherever salt goes, what follows? Fluid. Okay. So the kidney has a drop in blood pressure, it doesn't like it, it releases renin, causes the constriction of the blood vessels, at the same time sends a signal back to itself and says, hey, hold salt. Stupid organ. Okay. And then the beta 2s. But when we talk about CHF, pathophysiology in a little bit, that does come into play. Beta 2s, okay? Muscle action, again, the bronchioles in the lungs, they have a lot of beta 2s, causes the lungs, the bronchioles to open up, allows us to get more air in. Constricts down on the GI system, so we're not getting blood to the GI, because I don't care if we're breaking food down, we don't need to be breaking it down at that time. Tells the liver to release some of the glucose in the form of glyconeogenesis, so it takes the glycogen stores and produces glucose from all that stuff. Again, all in the fight or flight. And then you have breakdown of fat.
So that's why we give the MAG in respiratory issues because of the smooth. It's a beta 2.
MAG binds to MAG receptors, and then actually will cause the release of nitric oxide, and it's the nitric oxide that does the release of the bronchodilation. Same way as nitroglycerin. Nitroglycerin gets into the system, it's converted to nitric oxide. Nitric oxide causes the release, or actually the MAG binds to, it stops the calcium process. So what does calcium do? Calcium binds to troponin, tropomyosin. Yes. So you have a competitive inhibition with magnesium to calcium.
But this is all done by chance.
Yeah. It's all done by chance. Exactly.
Big bang.
All right. Physiology. All right. Again, we talked about the regulation. There is the heart is regulated by a electrical side, okay, and it's regulated by the endocrine side, the hormonal side. So inside the brain, the autonomic nervous system innervates the heart. If you look on the bottom right from that, it's the nucleus tractus solitaris. This pathway, love this pathway. I quiz medical students on it all the time because no one ever remembers it. But it's the pathway that controls our heart rate. Right? So when you stand up, what happens to our body? Blood rushes to the ground. Okay? So the blood rushes to the ground, where do we sense blood pressure changes? The two locations. What? Aortic arch and if you were to cause a vagal stimulation, where do you guys rub? Carotid. Okay? So the carotid arteries in the aortic arch. That's where the baroreceptors are. Okay? So when you do a carotid massage, you're actually stimulating the baroreceptor, which sends a signal to here, which then tells, because you're increasing the pressure, okay? When you increase the pressure inside the carotid, it says, hey, I have a lot of pressure. What does that do to the heart? Does it need more pressure or less pressure? Or more heart rate or less heart rate? Less heart rate. That's how we actually stimulate the heart to stop. It's that pathway. All right? So you get pressure receptors to the nucleus tractus, sends a signal back to the heart, either increase the heart rate or decrease the heart rate. Because what does the body want to preserve? Circulation, cardiac output. It needs to preserve cardiac output. And cardiac output is, what's the formula for cardiac output? Stroke volume times heart rate, which we'll get to in a bit. All right. So the afferents, okay? Afferent versus efferent. Afferent means it's taking signals and it's pulling it into. Okay, it's getting it from the extremities and everything else, and it pulls it to the brain, and then the efferent sends a signal back out. So the brain is always collecting data. Okay, it has the arterial chemoreceptors. So it actually, from there, it can look at the pH balance. Okay, do I have enough pH there or not enough pH? It's looking at the sodiums, it's looking at the potassiums, it's looking at all those little pieces. The baroreceptors, aortic arch, carotid body. Again, pressure changes. Okay, pressure drops, it's going to speed things up. Pressure increases, it's going to slow things down. From the muscles, okay, if you're to run a marathon, what is your body producing? You're producing lactic acid. So it senses, hey, I'm getting more lactic acid. What does the body need to get rid of the lactic acid? I need to breathe it off. How do I breathe it off? Increase respiratory rate. But when I increase my respiratory rate, what am I bringing in? I'm bringing in oxygen. So I'm going to go from a anaerobic state to a aerobic state, which goes back into which organelle? Inside the cell, the mitochondria. Okay.
Powerhouse of the sun.
So the powerhouse, exactly. So it takes oxygen and it goes from the Krebs cycle to the electron transport chain as the final electron acceptor is oxygen to produce water and CO2. That's the patho. And then it gets information from the kidneys, the peripheral vasculature, but then from there, conversely, it sends it back out. Okay? Squeezing the vasculature down, telling the heart to either increase or decrease, and telling the kidneys either hold salt or get rid of salt. That's the efferent. This is the normal. Okay? I said we talk about it, let's talk about it. Okay? So cardiac output is
Stroke volume times heart rate.
stroke volume times heart rate. Stroke volume is based upon three things.
Ideal.
Stuff coming back, which is called preload. The heart is pushing against is the afterload, and how well the heart squeezes is called the ejection fraction, or
Vascular resistance.
that's the contractility. So the vascular resistance is the afterload. Right? The systemic vascular resistance is our afterload. How much the heart has to push against. Stroke volume times heart rate, stroke volume out per squeeze. We push out 70 mLs approximately. Okay, our heart rate is about 70 at rest. That's how we get our 5 liters, 4,900 mLs of blood circulating per minute. The ejection fraction is how much blood is kind of sort of is there during the relaxation phase. We're good 50 to 55% is a normal ejection fraction. When you get below 40, you have problems. When you get below 20, you need a AICD because you're at risk of having VFib, VTAC like that. You look funny, you get go into VFib, VTAC. So that's why they need an AICD. Heart rate factors, okay? Metabolic stuff, temperature. They say about every degree of increase in temperature increases your heart rate by 10. Kind of sort of play from there. Yes, this area, methamphetamine, cocaine, those sort of things, does have a factor in play. Okay? Popo scaring you, get a little bit of stress. So the stroke volume. Stroke volume is our preload and our afterload. We have a direct impact on this. Right? So you have that CHF patient. Right? What can we open up to stop preload coming back to the heart? Increase the vascular system. So how do we increase the vascular system? How do we increase the veins? What do we give them? What? Handful of nitro. Okay.
Nitro paste.
Nitro paste. Love it. Not. Okay. Nitro paste is like D50, the devil. So a beta blocker does on the heart rate side, but what else? EMTs, what can you use to help with preload? What do you guys have? What can you put on their face? CPAP. All right, not just oxygen, but the CPAP. CPAP does what? Increases intrathoracic pressure. That does what? Decrease volume return. Okay, that's how we do the preload side of it. The afterload is how much the heart has to push against the systemic vascular resistance. How much is it pushing against? Okay, it has a constricted down aorta. The blood vessels are constricted because we got the patient on 60 mics of Levophed and 20 mics of epi and vasopressin. It can't push anymore. Okay, so that's what the heart pushes. So in a CHF patient, we can actually give them meds to release the afterload. High dose nitro will cause afterload reduction. Nitroprusside, lisinopril, your captoprils, and all that stuff. And then ultimately, it's the contractility. Right? Think of the heart as a rubber band, a balloon. Okay? If I blow the balloon up too much, I put too much in, what's going to happen? LVH, and it's going to pop. Right? If we put too much into a balloon air, it's going to pop. Right? If we take the rubber band, we stretch it too far, it's going to break.
And it loses that ability to constrict all the way, so you get that less force coming out.
Correct, because it does what to the actin-myosin filaments? It stretches the actin-myosin filaments apart so they can't grab to each other. So the troponin and the myosins, they can't grab and latch and pull like a ratchet system. They can't pull everything back together. So we have to allow the heart to get closed back down again. This is the Starling curve, okay? Getting into the stretch process. The Frank Starlings, if we're not enough versus too much versus we want them just right, okay? I guess it should be called the Golden Lock and the Three Bear process.
Just triggered a memory from medic school that I hadn't been.
That's what I'm here for.
I was like, we did go.
That's what I'm here for. All right. So inside the vasculature, okay, again, arterial process, blood, venous, microcirculation, the arteries and all that stuff. That's the conducting. That's our highway. That's our interstate. We have big interstates. We're trying to get cars down the road. It's not 5 o'clock on I-85. We don't want congestion. We want them at 2 o'clock in the morning and just speeding through. All right. That's the whole process of our arteries. The veins is our subdivisions, okay? We have a whole bunch of subdivisions. There's a whole bunch of houses, okay? The microvasculature, the microcirculation are our houses. It's our driveways. How many do we have? We have millions of them, okay? What do we do in our driveways? We take the groceries out of the car, we take it inside, we take the trash from inside, we bring it to the dumpster. Everything occurs inside at our house, at our microcirculation. And that's the process of going through. So again, the arteries, they're the conducting, the capacitance, okay, the veins and the venules. The majority of our blood sits and lives inside the capacitance. We have the ability to adjust the capacitance vessels, okay? You can dump and hold a lot of blood there. Conversely, if we put them on a levo-fed drip, which has what type of properties? What's the predominant hormone receptor? Peripheral constrictor. So what receptor is that? Which alpha? Which beta? Which one is it? Alpha 1, because alpha 1s do what? Constrict. So you have alpha 1s in the periphery, they squeeze down, you have all this blood that's just sitting there. What does that do? It gets pushed back to the heart, which is, by definition, that is called, if I have blood and fluid, then I put it back to the heart, that is the preload. Okay, that's increasing preload. When I increase preload, what do I increase? I don't increase afterload. When I increase preload, I increase stroke volume. When I increase stroke volume, I increase cardiac output. That's the process. Okay? All right. So two pathophyts. We'll talk about MIs and then we'll talk about the CHF. So there's a whole bunch of different processes of why we have MIs. Okay, you can either have coronary vasospasms, you can have drug toxins and all that stuff, or the thrombus formations and going from there. Plaques rupture off. It causes, you can actually have direct toxic, damages the cells spill out things, which in turn leads to the infarction process and all that stuff. The accelerated atherosclerosis, we know that cocaine will do that. Okay, it enhances the sclerosis by about 10 to 15 years. With using cocaine, right? Endothelial dysfunction, ultimately that's what leads to the MI, right? On the left hand, the increased myocardial oxygen demand, okay? This is, again, the question is like, oh, hey, doc, this is why you like Versed so much. Yes, okay? When I'm stressed out and I'm anxious, what happens to my heart rate? When I increase my heart rate, okay? We know that it's a direct correlation. When I increase heart rate, I increase oxygen demand. Okay. What happens to coronary perfusion when I increase my heart rate? It decreases because the valves are staying open, so I don't get coronary perfusion. I don't have ventricular diastole going on. So that does how does that do with our oxygen inside the coronaries? So it decreases. So I'm decreasing the amount of oxygen. I'm increasing the demand. which does what to the cells? Puts them into anaerobic metabolism, lactic acid formation, and they don't like it. They get pissed off and they die.
I know I'm like on your
Okay. All right. So this is why I like Versed, because what does Versed do? Relaxes you, chills you out. Okay. When I chill you out, what does my heart rate do? My heart rate decreases, my oxygen demand decreases, and allows for what? Coronary artery perfusion. I get more oxygen in, I can actually de-evolve a STEMI. Understanding the pathophysiology. Okay. Conversely, let's talk about CHF. Okay. So the same thing. We have an unfortunate mismatch going on. We're not getting oxygen to the cells. Okay. When we don't get oxygen to the cells, what do they produce? They produce lactic acid because we're not going through aerobic respiration. Okay. So what does that tell the heart when I increase my lactic acid? What does it tell the heart to do? Pump harder and faster, which in turn, if you already have a heart that's screwed up and it's not working, it's not pumping well, has an EF of 20%, how well can it pump? Okay. So from there, we also have problems in the chemoreceptors and baroreceptors. We're not getting the blood. So again, that's telling the heart to pump faster, pump harder. The kidneys, okay? Again, the kidneys are a stupid organ. Okay? They don't know any better. They don't see blood supply. So what do they release? The kidneys release renin. Renin then causes the release of angiotensin, which is then angiotensin 2. Angiotensin 2 does what? It's an alpha 1. It's a constrictor. So it's going to constrict on our blood vessels. Okay. What's that going to do?
Send blood back to central circulation.
Send blood back to central circulation. So I'm going to increase my preload, okay, on a heart that's already been stretched. So what happens further? Stretches it even further, okay. I don't have the actin-myosin to be able to bind, okay. So what does our blood pressure look like? Our blood pressure goes up, okay.
But only for a short time.
Only for exactly. So then from there, we also have what is angiotensin and angiotensin 2. Okay, then it loops back around to aldosterone. What does aldosterone do? It's a steroid that tells the kidney to do what? Retain salt. When I hold salt, it holds fluid. So now this is how we have more fluid buildup. Okay. Again, it's a stupid organ. So this is our process. So now we have a heart that's floppy, that can't push, can't constrict, and I'm being pulled apart. This is why we have SCAPE. Okay? Severe crash acute pulmonary edema. We have to unbind this process. Giving nitro, CPAP, go from there. Because we have to stop the cycle. All right? We good? Yes? All right. So, heart anatomy. Heart physiology, okay. We have the anatomy, both the structural and the electrical. We talk about action potential, and then from there we talk about the heart physiology, and then we talk about MIs and CHF. Okay. So getting back into a little bit more of the documentation, there's always been discussions going, Doc, we don't listen to heart sounds. We weren't really taught. This is why we're going to keep going through this. If I have to bring in different heart sounds every month, I will, to give you guys a feel for this. Okay? Because we can listen and listen and listen. Unless you take a stethoscope and put it on there every day, every patient, you're not going to know the difference. You got to do it. That's the only way. All right, heart sounds. All right, S1, S2, this is the lub and the dub. All right, this is the closing of valves. That's all it is. S1 is the closing of the tricuspid and bicuspid. All right, so what phase are we in? We're in systole, so we're in ventricular systole because it's forcing the valves to be closed. The semilunar valves open up, so when the ventricles relax, they close back down again. That's the dub. That's the S2, so that's ventricular diastole. And then S3 and S4 go from there, and we'll talk about all the rest. Okay. I was taught a long time ago in nursing and all that stuff, the location, APTM, so all physicians take money. That's the mnemonic for the locations, all that stuff. So second intercostal space, right sternal border is the aortic. So if you think about the anatomy of where the aortic semilunar valve sits, it's sitting, in this area, the third or fourth intercostal, and it's pointed up to the right side of the neck. Just the location of how it's sitting. Okay, comes out the aorta and loops around and goes back down. The pulmonic valve, right? Same thing. The heart sits in the third and the fourth, so the pulmonic valve is pointed towards the left shoulder. That's why it's good to listen there at the second intercostal. The tricuspid valve, the heart sits a little bit to the left, but at the right atrium, okay, and the right ventricle. Actually, it's the right ventricle is the one that's closest to you. To stab somebody, that's the first chamber that you would hit, would be the right ventricle. So that's the location of where the valve shoots its sound to. And then the mitral valve, it goes down towards the apex or the apical pulse, or the point of maximal impulse, the PMI, is at the fifth intercostal space. So tricuspid fourth, mitral fifth, and then over the ventricles, and again, that's the apical pulse or the apical area and all that stuff. All right. This is the website. Deidre will send out later. Okay. Put on the window work or whatever. Okay. Listen. Just keep listening. All right. That's the only way that you're going to get to. All right. So S1. S1 is the lub, the dub. Okay. Again, the lub, the mitral, and the tricuspid valves are closing. They close up. They make a sound. Right. Beginning of ventricular systole, diaphragm, apex. Okay, good, whatever. That's what they say. Lub dub, lub dub, lub dub, lub dub. Okay. So the S2, okay, that's the dub. Right. The aortic and pulmonic valves are closing. We're starting to get into ventricular diastole. What occurs during ventricular diastole? What gets filled? The ventricles and the coronary arteries. Okay. So the semilunar valves are closing back. Blood's filling backwards. You have passive blood coming from the aorta into the ventricles and then ready to constrict again. Right? Love, dub, dub, love, dub. Right. Conversely, a split S2. Right? Sometimes the aortic and the pulmonic valves, when they close at a little bit different timing. Okay? We'll see this in kids, younger kids and all that stuff. All it is just because of on the respiratory. The heart, when they breathe in, actually can constrict down the heart, and it causes the valves to close at different times. Right? It's all pressure gradients is all that is. Not a huge problem in kids. Adults, yeah, they still have it. Might be a little bit of a problem. And again, all that it is just that the aortic and pulmonic valves are just closing at a little bit different timing. That's all that is. S3s. Right. Under 30 could be normal, but if you're getting over 30 and you have signs and symptoms of heart failure, this is just the aspect of the concerns that it might be an impending CHF process. Extra filling sign, so you get the Kentucky, just like you're galloping down. Right? So that's why it's the S3 gallop. Do your little galloping. versus the S4. The S4 on diastole, what's happening during ventricular diastole?
The atrial constricting.
The atrials are start constricting. Okay, the ventricles are getting the filling. Okay, so they're trying to fill. So on an S4, what happens is that once you get the atrial systole go on, it's squeezing blood into a stiff ventricle. The ventricles don't like it, right? So they get pushed out. Right? And when they get pushed out too hard and they're already stiff, that's how you get an extra sound. So that's what the Tennessee is. Right? Yeah, the valves and all of that stuff having problems. Tennessee, 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 Tennessee. Mitral regurg, most common valvular apathy that we see. All right, young females, you can have girls in their 18s and 20s that can have this. As we all get older, over 60, we will have some form of regurg. Right, it's normal. And the mitral valve is the most common for the regurg from that standpoint. Again, when does the mitral valve close? During ventricular systole. So the ventricle is starting to squeeze, it snaps back. The mitral valve snaps back, and then it can't hold it. Either the chordae tendineae or the papillary muscles are too loose, so it forces the blood backwards, or forces the leaflets into the left atrium, and you have blood being pushed back into the left atrium. That's what the regurg sound is. So you hear it during systole. All right, so the lub-dub side of it. So you get the lub and the dub. So the flow is during systole, so it's in between the S1 and the S2, because that's when those valves close.
That would be an S1, but S2 and 3 with a.
Yeah, you may have a little bit of S3 on this one, but the mainstay is it's the murmur, it's the regurg. Our most common that we talked about a couple months ago, pediatric congenital heart disease, okay, is the VSD. Okay, most common heart defect, and again, the flow side of it. During the ventricle, you have a hole in the septum, the ventricle septums. So during ventricular contractions, you have blood that's being pushed from the right side over to the left side through the hole. Right? So you get the aspect, you'll hear the S1, the S2 there, but you have the flow murmur that's going on. Different pitch. Yep. You can actually, you can have an accented. Usually, this is what they call a holosystolic, meaning that's through the whole phase, versus a regurg. It might be only during different parts. Questions, comments. Again, anatomy, cardiac physiology, electrical system. From there, we talked about the action potential, got down to the pathophysiology of CHF and MIs, and then get into the heart sounds. Right?
Would you hear anything from if they have ASD? What is that something you would be able to hear?
You can hear a patent foramen if they have a recurrent or patent foramen valley. Yeah. Again, it's a little bit of a holosystolic type process. Usually not as pronounced as a VSD. And they look at that more during like an echo and all that stuff.
So if I hear an abnormal heart sound and I'm not sure what it is, what do you want me to do to document?
Just document abnormal. I mean, if you can sign a tease out, is it during diastole? Is it during systole? I mean, even if it's just documenting going, I hear something abnormal. The regular brain rhythm, and I hear murmur. If you can't describe murmur, that's fine.
Yeah.
but that's where I want you to get the guys' process through.